So can you see the PowerPoint now?
Yes, doctor.
Okay. So today is our third lecture in urinary physiology, which is about glomerular filtration. If you remember in the first lecture that we took about the general outline of the renal physiology, in that I described the parts of a nephron, kidney in general. Then we discussed the parts of the nephron. So what is a nephron? Can anyone tell me what is nephron means?
Functional unit.
Yes, it's a function unit. What are the parts?
There's glomeruli, Bowman capsule,
Okay.
proximal convoluted tubules, lobe of Henle, and distal convoluted tubule.
Very good, very good. So you must remember all these names because first part is today's lecture is about glomerular filtration rate, which we will discuss the filtration of plasma in the glomerular part. So if you remember, I shown you what is mean by glomerulus. What is this, which is I am drawing now?
Bowman capsule. Bowman's capsule.
This is Bowman's capsule. Yes, good. In Bowman's capsule, the blood supply comes from afferent arteriole. From afferent arteriole. This blood once it afferent arteriole once enter into the Bowman's capsule, it will become capillary. Okay. So there are so many loops of the capillaries are there. I'll just draw the ball like a tuft of capillaries, and then it will go out as efferent arteriole.
Efferent.
Yeah. So blood which is coming here and then filtered, because you know that capillaries are having pores or fenestration. So the blood which is coming here will be filtered. We call it as glomerular filtration. We call it as glomerular filtration. Okay. So today's lecture is about that filtration only. This is called as glomerular filtration. In this lecture, we will be talking about hemodynamics, that is how the blood is flowing into the kidney or into the nephron. Then we will talk about how the glomerular basement membrane look like, how the membrane through which, let's say I will draw a diagrammatic representation of the capillaries. This is the afferent arteriole. When it comes, it will become fenestrated. And when it goes out again, it will become a efferent arteriole. Okay, so blood which is present here will be filtered through these pores or through these fenestrations. So there is a membrane here. We call it as a glomerular basement membrane. So we will see the structure of that glomerular basement membrane, because if there is any problem, then the glomerular filtration will increase or decrease. Okay. Now, when we say the fluid is filtered or the plasma is filtered, if we take this filtration in terms of time, per unit of time, per minute, per second, per hour, or per day, we call it as rate. We call it as rate. Glomerular filtration per unit of time is known as glomerular filtration rate. So for the filtration to occur, there are some forces. Maybe force of blood column, maybe force of attracting force like colloidal osmotic pressure, maybe the force which is pushing from here, maybe from here, some force is in the opposite direction, some force may be in the opposite direction. So these forces we will discuss because this will change the glomerular filtration. And then how it is regulated automatically. Autoregulation means there is nothing will come from outside. All the filtration will be regulated on its own. increase or decrease. If there is a decrease, it will automatically increase. If there is an increase, it will automatically decrease. This is called as autoregulation, regulation within the organ. So how this glomerular filtration will be regulated on its own, we will see that one. And then describe the structure and function of the juxtaglomerular apparatus. Juxtaglomerular apparatus. Okay. We will see the structure we have already seen, but we will go in detail and how it will function. Then we will see the what are the conditions in which there is a change in the GFR. GFR will either sometimes increase or in some diseases it will be decrease. Diseases or clinical conditions. So we will see that. What are the factors which are affecting the GFR? We will see that and what we call these conditions. Okay. So this is a repetition of the previous slide. Whenever we say urine is formed by three processes. Number one is filtration. Whatever blood or whatever plasma is entering into the glomerulus, some of it will be filtered. So this is called as filtration, or it is occurring in the glomerulus. That's why it's called as a glomerular filtration. Then let's say glucose and water and sodium chloride is filtered, which these things are essential for the body. So it should not go into the urine. It should not go into the urine. So what the nephron will do? Nephron will try to absorb them again into the blood. This is called as reabsorption. Re means because this is absorption is taking place second time. First time it was absorbed in the GI tract. Now second time it is absorbing in the kidney. That's why it's called as reabsorption. Then it's not all the plasma is filtered here. Let's say 1 liter of plasma entering here. Let's say 1 liter is coming to the Bowman's into the glomerulus. Out of that, as it is a continuous process, sorry. I will reshare, stop sharing because it's suddenly gone out. So three processes are there in the actual formation of urine. First is filtration. Second one is reabsorption of the essential material. And third thing is, as I am telling you, that if 1 liter is reaching here, out of that may not be all 1 liter is filtered. It is maybe 20 or 200 ml will be filtered, whereas 800 ml will go without any change. Why it is stop again? Resume. Okay. So 800 ml will continue as filter. Sorry, this is 800 ml is continued into the peritubular capillaries. So for that one, to add this 800 ml will contain maybe the waste product like hydrogen, urea, or ammonia. Ammonia. So it has to be removed. So that's why the third step will be secretion, tubular secretion. As it is secreted in the tubule, that's why it is called as tubular secretion. So we can suggest that the formula for urine formation or urine excretion is equal to filtration minus reabsorption, because this is taken in reabsorption, then adding secretion. So secretion will be added. This is the final formula for urine formation. Now we will talk about in today's lecture about filtration, first step. Okay. First is definition. What is the definition of glomerular filtration rate? It is the volume of plasma filtered from both kidneys from both kidneys in all the nephrons of both the kidneys in how many times? How much time? Per minute, in 1 minute. In 1 minute. So if you see, this is the Bowman's capsule, and this one is the glomerulus. So in 1 minute, how much plasma is filtered? We call it as glomerular filtration rate. Glomerular filtration rate. If you collect all the filtration, you will find that it will be about 180 liters in 1 day. In 24 hours, how much plasma is filtered? In 24 hours, 180 liters. If you want to know how much is per minute, it is about 125 ml per minute. In 1 minute, 125 ml of the plasma is filtered here, coming into the tubule. So formula for GFR is equal to filtration coefficient. There is some constant value which is called as filtration coefficient, multiply by net filtration rate. Net filtration rate, because or sorry, net filtration pressure. With how much pressure there is a filtration is occurring, we call it as GFR. Formula for GFR. GFR is equal to filtration coefficient multiplied by net filtration pressure. Maybe there are some pressure which is helping to for the filtrate to increase, and there are some forces which will cause decrease in the filtration. So the total of that is called as net filtration. Okay. I will not ask you in the exam about how to calculate. So no, don't worry about the formulas. Just remember what are the things there in the formula. For GFR depends upon, you can say indirectly, GFR depends upon KF, that is filtration coefficient, and net filtration pressure. GFR depends upon two things: coefficient of filtration and net filtration pressure. We will see what are these. Okay. So as I told you, glomerular membrane is formed by the capillaries and some other things, and it will be very permeable, more permeable than any other capillaries, because the fenestration size is, it's not continuous, it is having gaps. It is having gaps. From here again it will become the efferent arteriole. So it has got holes or gaps, you can say. It has got holes or gaps. That's why it is more permeable than any other capillary. More permeable than any other capillary. How it is formed? Because it has got a capillary wall is a single layer of endothelial cells like this, with in between there is a gap. Or we call it these areas as fenestrations. These called as pores or fenestrations that make it 100 times more permeable to water and solutes than any other capillaries. Because of these gaps, because of these gaps, it is becoming 100 times more permeable to water and other solutes compared to any other capillary in the body. That's why it is giving you filtration. Okay. Basement membrane will not allow, or it is composed of, it does not have any cells. It does not have any cell, but it is composed of collagen. After this endothelial cells, there is a layer of collagen and glycoprotein. Collagen and glycoprotein are there here. Remember word protein. So glycoprotein is negatively charged. As I said, why to remember? Because proteins are negatively charged. Then inner layer of Bowman's capsule, followed by inner layer of Bowman's capsule. You have got, first is the capillary, which is having holes or fenestration. Then you have got inner layer of Bowman's capsule, this one. And it has got again cells. and this is outer layer. Okay, so this is here is the actual filtrating membrane. Inner layer of Bowman's capsule, it contain epithelial cells. But these epithelial cells has got a special name known as podocyte. Each podocyte has foot process. So these cells are not like round. It has got some foot process like this. They are not rounded cells. They are having some projections, which we call it as foot processes. Now one cell is sitting into the other cell. So this will become a slit, just like if you hold your hand, the fingers like this, you will find that there are some lines or junctions between two parts of your fingers. When right hand finger and engulf with the the left hand finger, it is not totally watertight. It has got some gaps. This is called as filtration slits. If you see here in the foot process, if you have another cell which will be fitting here, so these gaps are called as the filtration slits. These gaps are called as filtration slits. I will show you in the diagram. Okay, this one. You will see that this is the afferent arteriole coming in, then dividing, and you will find that there are podocytes. These are called as podocytes. So podocytes are one cell and this is another cell, and they are like this. This is one podocyte and the second podocyte will be, sorry, I will draw with a different color so you will understand. First, let me erase. Okay. So one podocyte and then comes the next podocyte. This is next podocyte. This was first podocyte. Sorry. La hawla wala. It automatically stops sharing. Share again. Oh, my PowerPoint is switched off. Okay, 1 minute, I will open again. I think because of the internet speed, there seems to be some problem. Sorry, it is opening very slow, very slow. Still not open. Can you see the PowerPoint now?
Yes, doctor.
Yeah.
Yes, doctor.
Sorry for this discrepancy, but maybe internet speed or my computer, I don't know. So what I was telling you, that podocytes are, one podocyte is like this. This is one podocyte. And the second one is, I will draw with another color so that you will understand what is the meaning of slit. It is sitting like this. So this gap is known as filtration slit. This gap is known as, sorry, filtration slit. Filtration slit. Here you will see it's here. These are the two, one podocyte is here, second podocyte is here. In between, there is a gap which is called as filtration slit. And again, if you want to see it under very high magnification, you will see these are the endothelial cells. These are the endothelial cells of the capillaries. Then second one is the basement membrane, which is made up of what? Basement membrane is made up of glycoprotein. Made up of glycoprotein. And then followed by third layer. Third layer is the podocyte. This is from the Bowman's capsule. This is from Bowman. These cells are from Bowman's capsule. And then there is a lumen of the Bowman. So you can imagine like this. So these cells are called as podocyte, inner layer. These cells are called as podocyte. And here is the capillary. And here is the basement membrane. So all three layers are there. From endothelial cell, it has got slits, filtration slits. Somebody is trying to join, maybe. I'll check. Who's raising the hand or?
So, doctor,
Yes,
when you I mean by the filtration sites, it's you mean in the same line of this wave in this picture, right?
yes. In this picture, it shows how the plasma is filtered. Plasma is here. Here in this side, plasma is there. Then it will pass through the fenestration or the filtration or the gap between the endothelial cells. Then it will reach to the basement membrane, which is glycoprotein. Then it will pass in between the two podocyte, that is called as a filtration slit, and then it will reach to the lumen of the Bowman's capsule. And from here, so this is filtered fluid will come here now, and then it will go to the tubule, proximal convoluted tubule, proximal convoluted tubule. Then going to the loop of Henle, then distal convoluted tubule, like that. Okay. Today we are talking about how the filtration is occurring in this area only. Okay. So for one is the lumen of the glomerular capillary. Second area is the in the glomerular basement membrane. Third one is the lumen. Inside this, then the filtrate will be continued in the proximal convoluted tubule, loop of Henle, and distal convoluted tubule. Here also it is showing. So what the filtrate will be look like? Suppose blood is coming, and then from the capillaries, it will reach into the lumen of the Bowman's capsule. So from blood, what are the things will pass and what will be the end result here? The end result, we call it as a filtrate, glomerular filtrate. We call it as glomerular filtrate. Here the blood, out of blood, only plasma will be passing. Only plasma will be filtered. Cells, RBCs, will not be filtered. Cells or RBC will not be filtered. So the thing which is reaching here, that is glomerular filtrate, it will contain everything except blood cells, protein, or protein bound some molecules. It could be calcium, it could be fatty acid, it could be amino acid which are bound to the protein. So they are not released or they are not joining the filtrate. You can say they are banned. They are having no entry. I will just say no entry. Okay. So in the filtrate, you will find everything except RBC, except protein bound some chemicals. Why? The reason is, you may ask me why it is not filtered. Why it is not filtered? Even though, despite the 3 layers of the barrier, the glomerular filters several hundred times as much water and solute as the usual capillary membrane. Even though there are 3 layers, this layer is endothelial layer. This layer is glomerular basement membrane. This layer is podocyte. Okay. Out of these 3 layers, still it is more permeable. It's still the amount of filtrate coming is a huge amount. Even with this high rate of filtration, glomerular capillary membrane prevents filtration of plasma protein. Why? Even though there are holes and there are filtration slits.
It has a negative charge.
Because of negatively charged. Yes, as we have seen that it is made up of glycoprotein, and which is a protein in nature. It is already negative in charge. And our protein, that plasma protein, is also negatively charged. So when they will come near to each other, they will cause repulsion. So that's why it will not come out through these holes. Okay. Even though if it comes out through these holes, there is a basement membrane which is consist of glycoprotein, and then there are podocyte. Okay. So 3 layers are there, and these 3 layers filter everything except RBC, plasma protein, and any chemical which is bound to protein. They will not come out into the filtrate. Now we will talk about the changes or filterability. So filterability depends upon which will be filtered and which not will be filtered, depends upon this. First is the size of the molecule, because the pore size of the glomerular membrane is about 8 nanometers. 8 nanometers is the size of these holes, okay, through which the filtration occurs. And also the charge of the molecule, which molecules have to pass through this hole. We have to consider whether it is positive or negatively charged. Because these holes are charged by a negative glycoprotein, any negative ions cannot pass through it, whereas positive ions can easily pass through it. So positively charged are filtered much more easily than the negatively charged of the molecule which are of same size. Suppose one molecule is like this, second molecule is like this, but one is positively charged, second one is negatively charged. So even though they look like same, but this molecule will not be filtered because it is negatively charged. The negative charge of the basement membrane and the podocyte provide important means of restricting negatively charged molecules for passing from plasma protein or passing from plasma to the filtrate. Although diameter of albumin is very small, less than 6 nanometer, and the size of the pore is 8 nanometers, still it cannot pass because of negatively charged glycoprotein. Any difficulty in this?
No, it's easy.
Okay, easy. Now coming to what are the factors? So for deciding the factors which are regulating the plasma protein, we have to see how much plasma is filtered. Suppose 100 ml of plasma is coming to the glomerulus. Out of that, how much is going to the efferent arteriole? And rest will be filtered. Okay, rest will be filtered or reaching to the Bowman's capsule and the tubule. So out of 100 ml, only 20 ml will be filtered. 20 ml will be filtered, whereas 80 ml will go as it is to the efferent arteriole, as it is to the through the efferent arteriole into the peritubular capillaries. So how much we can say fraction out of if you say 100 ml, it is only 20%. Out of 100 ml, 20 ml, that means 20% is filtered. This is called as filtration fraction. Fraction means if this is a whole thing, out of that you are having this much amount filtered. Out of this much amount is filtered. So we say it is the 20% of the total 100%. Okay, so this is called as fraction, fraction or a part, piece or a small piece. So 20% is filtered. We call it as filtration fraction. Filtration fraction. Okay, so GFR depends upon, or glomerular filtration rate depends upon two things. Number one is net filtration pressure. Net filtration pressure. And second one is coefficient of filtration. Or some constant. It is some constant. These are the two factors which is deciding how much the rate of glomerular filtration. Okay, what is how we calculate the net filtration pressure? Net means which pressure is causing filtration and which force is causing opposition of filtration. The sum total, or you can say difference between them, is known as net filtration pressure. So net filtration pressure is forces which are helping to filtrate and forces which are opposing to filtrate. Okay. So what are the forces? Again, we have to go back to the previous block, PHSL block. How many forces are there in the blood for filtration? Two types of forces exist. One is called as colloid.
Colloid
Yes.
osmotic.
Colloid osmotic pressure. Very good. And second one is
Hydrostatic.
Hydrostatic. Okay.
Pressure.
Hydrostatic pressure. Okay. These two types of pressures are there. Now a colloidal osmotic pressure will be inside also, inside the glomerular capillary, and also outside in the Bowman's capsule. Outside means in the Bowman's capsule. Similarly, hydrostatic pressure will also be within the capillary. Suppose this is a capillary. So hydrostatic pressure here also, and some pressure because of the collection of fluid into the Bowman's capsule also. Some blood is or some plasma is coming here. So that's why there will be hydrostatic pressure. So two pressure, one inside, one outside. That's why it will become 4. So colloidal osmotic pressure. Who will tell me what is the meaning of colloidal osmotic pressure? Somebody should tell me what is mean by colloidal osmotic pressure. Without that, you will not understand. No one? Suppose this is a blood vessel or a capillary. Okay. So here you will have RBCs and also you will have plasma protein. Got it? This is a capillary. It has got cells as well as water as well as proteins. What is mean by osmosis?
Water.
Osmosis. Osmosis means what?
It's something related to water.
Something. What is that
moving
something?
from high concentration to low concentration.
Very good. Very good. Osmosis means diffusion of water or movement of water. Okay. Movement of water. This is called as osmosis. And osmotic pressure is pressure which prevents osmosis. Pressure which prevent osmosis or stop osmosis is called as osmotic pressure, is called as or is known as osmotic pressure. The one which is required to stop osmosis or stop the movement of water, we call it as osmotic pressure. This much pressure is required to stop osmosis. That's why it is called as osmotic pressure. Now, why it is called as colloidal? Because this osmotic pressure is mainly because of the protein. Mainly because of the protein. These protein will hold the water with them. Protein will hold the water with it. This is why it is called as colloidal osmotic pressure, holding pressure, pressure which is holding water with it. So for example, the colloidal osmotic pressure is 50 minus the opposition pressure, that is 33 millimeter of mercury. I will tell you the actual numbers afterward. But if you see this 55 minus 30 plus 15. 30 plus 15 is how much? 5 is 5 and 3 plus 1 is 4. Okay, 45. 45. And here is 55 minus 45. How much? 55 minus 45 is 10. So 10 millimeter of mercury is the net filtration pressure. The pressure which will cause filtration to occur is 10. But why it is coming 10? Because of 55 minus 30 plus 15. Okay. We will see what is this 30 and what is this 15 and what is this 55 in the next slide. So glomerular filtration depends upon net filtration pressure, and it also depends upon how much glomerular surface area available. If this much surface area available, filtration will be, let's say 15 ml per minute. If this much surface area is available, filtration will be more or less?
Less.
Less. Instead of 15, it may be 1 ml per minute because this is surface. So it depends upon surface area. If surface area becomes more filtration will occur. If surface area becomes less filtration will occur. But what surface area we are talking about? We are talking about surface area of glomerular filtrating membrane, the membrane through which the filtration is occurring. Okay. And also depends upon permeability of the any content which is present in the blood. It may be permeability of protein, it may be permeability of sodium, it may be permeability of calcium, like that. So how the glomerular membrane is permeable to one particular ion or a molecule, it will decide whether it will be filtered fast or slow. That is filtration pressure rate. Now see what is the meaning of this 50, what is meaning of this 30, and what is the meaning of this 15 in the next slide. So basically, as we said net filtration is nothing but the resultant pressure of four things. One is PGC. What is this GC means?
Glomerular capillary.
Yes, good. This is known as glomerular capillaries. And this pressure P is for hydrostatic pressure. Hydrostatic, or you can say simply the blood pressure present in the glomerular capillaries. Hydrostatic pressure is P. Okay. What is this sign? What is this sign? This is the name of the sign is pi.
Yeah.
Yeah, this name of this sign is in mathematics, it is pi.
Wow.
And what is this GC? Glomerular capillaries. So this sign we use it to denote osmotic pressure. Osmotic pressure. Where? In the glomerular capillaries in GC. So pressure, glomerular capillary hydrostatic pressure and glomerular capillary colloidal osmotic pressure, these two pressure are opposite to each other. opposite to each other. Whenever we say osmotic pressure, it is the one which is preventing osmosis. That means prevention of the filtration. Similarly, the third factor is, what is this P again? Same like here.
Hydrostatic pressure.
Yes, it is also known as hydrostatic pressure. But where? BC.
Bowman capsule.
It is Bowman's capsule. Very good. You are making my life easy.
Doctor?
Yes.
Okay, so again, the pi is the force that prevent the filtration,
Yes,
right?
it is called as colloidal osmotic pressure. Yes.
Okay.
Same thing, pi, but in Bowman's capsule now. Okay, so I will draw it here. I will draw the Bowman's capsule here. Okay, and I will draw the capillary in a diagrammatic fashion. Just one capillary, okay? So this area is capillary area, okay? This area. In this area, inside you will have hydrostatic pressure in glomerular capillary. You also have protein, which is giving osmotic pressure. So it is pi C, okay? This pi C. Where is pi C? GC or capillary or GC, okay? Then you will have fluid accumulated here. This is in the Bowman's capsule. So in this Bowman's capsule, also you will have hydrostatic pressure in Bowman's capsule. And maybe because of protein, there can be, I will tell you what is the value here for pi BC. Okay. In the first few slides, I told you that filtration will have everything except what?
Protein or
Protein.
RBC.
So that means protein will not be here because it is not filtered, huh? It is not coming into the Bowman's capsule. So protein will not be there. So pi BC will be 0, right? Pi BC will be 0. Okay, next thing. What other factors responsible for glomerular filtration is permeability. How permeable for any ion, this membrane or this capillary, and how much surface area is available. This much surface area or this much surface area. Depending upon that, it may be less here, it may be more here, the filtration rate. Okay, now go to the next slide. Normally Bowman's capsular, see here, I told you that there is no protein filtered. That's why pi BC is 0. Now coming to the actual calculation. Although calculation will not come, but you have to know what are the things responsible for GFR. So glomerular filtration rate is equal to net filtration pressure multiplied by filtration coefficient. That will be counted in terms of minutes, ml per minute, ml per minute. Now see, net filtration pressure is equal to the glomerular capillary pressure minus glomerular capillary osmotic pressure minus glomerular capillary, the Bowman's capsular hydrostatic pressure. Anything else? Anyone want to ask me question? Now, this hydrostatic pressure is around 55 in the capillaries. The pressure is around 55. This is called as hydrostatic pressure in the capillaries, which will allow the filtration to occur. But there are plasma proteins which are holding the water, not allowing the water to go out into the Bowman's capsule, which is equal to the pi GC is equal to 30 millimeter of mercury. And once the fluid enters into the Bowman's capsule, here the fluid enter into the Bowman's capsule, This is also having some pressure, but this pressure in this direction, opposing force. And this is around 15 millimeter of mercury. Now, let me draw the diagram again. Now inside there is 55 millimeter of mercury, which is going in this direction. This is the pressure because of the water content. This is called as hydrostatic pressure. P glomerular capillary is 55, this one. And there is pi BC, pi GC, that is glomerular capillary osmotic pressure is about 30, which is in this direction, opposite, in this direction, opposite. And there is pressure occur due to the fluid accumulated outside the capillaries, but in the Bowman's capsule, which is about 15. Again, it is opposite force. So two opposite forces are there, 30 and 15. So you will say total opposite force is 45, 30 plus 15. This is negative pressure and 55 is the positive pressure or the favoring pressure. What is the total? Total will be plus 35, plus 55 and minus 45 is 10 millimeter of mercury. This is called as net filtration pressure. If it becomes 11, then the filtration will be more. If it becomes 5, filtration will become less. This is a simplified diagram to show you where the pressure, which pressure is in which direction. This is glomerular capillary blood pressure or hydrostatic pressure. This is in this direction. So it will cause filtration. Then there is a plasma colloidal osmotic pressure. This is pi GC. It is holding the pressure. That means it is in the opposite direction. Then the third pressure is Bowman's capsular hydrostatic pressure. Pressure occurred because of the fluid here, which is again not allowing the fluid to come out. That is 15. So net filtration pressure is about 55 minus 45, which is equal to 10 millimeter of mercury. Any difficulty in this?
No, doctor, quite.
Inshallah, you will remember. So explanation of these pressures are given here. Glomerular capillary hydrostatic pressure or blood pressure is, it depends upon how much is the force of contraction of the ventricle and what is the speed of flow, because it depends upon resistance. Both these factors will increase or decrease the Bowman's capsule, the capillary hydrostatic pressure, which is a major pressure. It is around 55 millimeter of mercury. Similarly, because of the presence of plasma protein, there is osmotic pressure is created, which is in opposite direction. And it is the quantity, depending upon the quantity of the plasma protein, it is 30 millimeter of mercury, and it is opposing force. Now, proteins may be lost in conditions called as known as maybe a burn. If the person is burned due to fire or any liquid, hot liquid or something, if it is severely burned, his skin will be exposed and there will be loss of plasma protein. If there is a loss of plasma protein, this 30 millimeter will be becoming maybe 20 millimeter or 25 millimeter less. Okay, this will become less. This will cause the opposing force to be decreased. Opposing force will be decreased. That's why GFR will be increased. So in severely burned patient, GFR will increase due to what? Decrease in plasma colloidal osmotic pressure. Decrease in plasma colloidal osmotic pressure. Similarly, if the person loses water, dehydration, let's say person suffering from sweating, excessive sweating, or not drinking proper water, or maybe due to loss of water in diarrhea. What will happen to the concentration of proteins in the blood, it will become
Will
more.
increase.
Yeah,
Yes.
it will be highly increased because water is loss minus water. So it will become more solidified. In that case, the opposing force, that is the 30 millimeter, will become more. In hydration, you will find osmotic pressure will be more. Osmotic pressure will become more. If osmotic pressure will become more, that means it will hold water more. And that's why GFR will decrease, or the fluid will not be filtered because water will be accompanied with the protein. Similarly, in the Bowman's capsule, sorry. In the Bowman's capsule, here, or rather, you can say here, if the fluid is accumulated here after filtration, because of this, there is a hydrostatic pressure is created here. This hydrostatic pressure will exert in opposite direction. This is also in opposite direction, which is around, normally it is around 15 millimeter of mercury. But suppose the kidney develops a stone or stricture here, then fluid will go on accumulating here. So there is a back pressure is increasing. This back pressure will increase in tubular obstruction. It could be due to stones, renal stone, renal calculi, or tubular necrosis. Maybe this area become necrosed and it will become closed or very narrow. May become narrow. So this pressure will be exerted here, and this is in opposite direction, and that's why it will lead to what? It will lead to GFR?
Decrease.
Decrease in GFR. So either stone or tubular necrosis will create this pressure to be more. Also in urinary tract obstruction, we have seen after this it will become the fluid will come out from the kidney into the ureter. Then ureter will join into the prostate, into the bladder. Both side it will join, and then urethra will be throwing the fluid out. If you know that there is a gland here at the before the urethra or at the neck of the bladder, which is known as prostate gland. If this prostate is enlarged, big, it will constrict the urethra, not allowing the fluid to go easily. So it will create a pressure here into the bladder, into the ureters, and into the kidney. That's why fluid will not be filtered properly. There will be more pressure. And this is capsular hydrostatic pressure will increase. This will cause decrease in GFR. So decrease in GFR occurs in renal stone, tubular necrosis, and prostatic enlargement due to which pressure? Hydrostatic pressure in the Bowman's capsule. Sorry. Unregulated influence on the GFR. Pathologically, plasma colloidal osmotic pressure and Bowman's capsular hydrostatic pressure can change. What it will change? Plasma colloidal osmotic pressure will be changing in two conditions. One is loss of protein, severe burn or dehydration. Severe burn, it will cause more plasma loss or the plasma protein loss. This will lead to loss of colloidal osmotic pressure, decreased colloidal osmotic pressure, and this will lead to increased in GFR. Similarly, dehydration will lead to concentration of the plasma protein or increase in the increase in the colloidal osmotic pressure in the capillaries, and that's why it will lead to the decrease in GFR. Similarly, Bowman's capsular hydrostatic pressure will increase in any obstruction like kidney stones or enlarged prostate. This will cause increase in Bowman's capsular hydrostatic pressure. PBC will be increased. controlled adjustment of the GFR. How the GFR is controlled. Glomerular capillary blood pressure can be controlled to adjust the GFR. Whenever glomerular capillary pressure, which is around 55, if you keep it 55, same amount of the filtration will be occurring. If this 55 is increasing or decreasing, then it will cause change in the GFR. So how this 55 is regulated? There are two mechanisms. One is autoregulation. Within the kidney, there are some methods which is regulating the capillary hydrostatic pressure, and that it will be ultimately regulating the GFR. Then there are some other mechanism. Another mechanism is extrinsic mechanism. When the nerves are supplying to the arterioles, that is called as a sympathetic control. This is also regulating the GFR. So two mechanism. One is within the kidney, that is autoregulation. Second one is from coming from outside, that is the sympathetic control. How autoregulation is occurring? Again, by two methods. One is called as myogenic mechanism. Second one is known as tubuloglomerular feedback mechanism. So just imagine first mechanism here. Blood is flowing into the capillaries. And it will create a pressure of 55 mm of Hg. That is the hydrostatic pressure in the capillaries. Let me clean this. Okay. Suppose more blood comes here. If the blood flow through the capillaries increases, this will cause the stretching of the walls, capillary walls. So capillary wall become stretched, and there will be, let's say it will increase the pressure to 65 millimeter of mercury. Sorry, 56. No, it will. Let's say it becomes 65, 10 millimeter increase. Because of this stretch, there will be again reflex contraction will occur, so that the pressure will come back to the same position, that is 55 millimeter of mercury. This is due to stretch mechanism. Smooth muscles are there in the capillaries. If more blood is flowing, it will stretch, leading to reflex contraction. So it will come back to the normal. And that's why the 55 will remain 55 millimeter of mercury. This is how autoregulation occurs. Autoregulation by myogenic mechanism. What is tubuloglomerular feedback mechanism? What?
Juxtaglomerular apparatus produce renin, secrete renin.
Yes, this is due to juxtaglomerular apparatus. As the name suggests, there is some communication is occurring between tubule to the glomerulus. This tubule, that is DCT, between DCT and the glomerulus, and this ball-like structure. So this communication is known as tubuloglomerular feedback mechanism. Tubuloglomerular feedback mechanism. I will show you. First is myogenic mechanism. This is myogenic. Myogenic means increased blood pressure will lead to afferent arteriole, more blood is flowing. It will lead to stretching of the muscles, and this stretching will lead to, or more blood is coming, more more capillary hydrostatic pressure. This will lead to more GFR. But this is not happening. This is regulated by reflex constriction. There is a decrease in the diameter of the afferent arteriole, which will decrease the blood flow, and the net filtration pressure will come back to the normal, and this will decrease the GFR. This is called as myogenic mechanism of autoregulation of the GFR. Similarly, another example where if more blood is there, more or less blood, sorry, less blood is there. In that case, kidney will try to filter the same amount by increasing the diameter, that is afferent arteriolar dilatation. This will lead to same amount of the blood reaching here, and then the GFR will remain same or you can say previously decreased, it will increase back to the normal. Coming to the tubuloglomerular feedback mechanism, for that you have to remember the juxtaglomerular apparatus, JGA. What is juxtaglomerular apparatus? It is the combination of what? Distal convoluted tubule. This is DCT. Sorry. This one. Glomerulus, Bowman's capsule. This is proximal convoluted tubule. This is going down to loop of Henle, descending limb and then ascending limb. And then it will become the distal convoluted tubule. It passes between the afferent and efferent arteriole, between here. Sorry. So in cut section, it will look like this. In cut section, it is looking like this. There is a efferent arteriole. This one is afferent arteriole. And in between, you will find the DCT. The cells which come in contact in this area of DCT, they will become modified. And they are known as macula densa cell. Macula densa cell. This macula densa cell, what they will do, they will check, always continuously checking the which concentration? Sodium concentration. They are checking the sodium concentration. Let's say GFR increase. So more fluid is passing into the proximal convoluted tubule. It comes to in distal convoluted in the loop of Henle, and then say more fluid is filtered. So more fluid will have more sodium ions. So more sodium ions will reach to the DCT. In DCT, these cells, macular densa cell, will detect that there is more sodium concentration. They will send the signal to the afferent arteriolar endothelial cells. Sorry. Give me a minute. Afferent arteriolar endothelial cells, which are modified, and they are known as granular cells. These granular cells are responsible for secreting renin. So whatever quantity of renin is secreted because of excessive sodium, renin secretion will decrease. Renin secretion will be decreased. And because of decreased renin secretion, there will be reverse back of, or flow will become different, or reverse back to the same position, that is the initial one. This is how it will function. Okay, this is the steps are shown here. Let's say increase in the blood pressure. So it will lead to more glomerular filtration rate because hydrostatic pressure is increased. So more GFR. More GFR will cause more sodium to be filtered. More sodium to the DCT will go, and then they will cause release of ATP and adenosine. This ATP and adenosine will cause vasoconstriction, afferent arteriolar constriction. This afferent arterial constriction will again bring the hydrostatic pressure or blood pressure back to the normal in the capillaries, glomerular capillaries, and this will lead to decreased blood pressure, and this will lead to decreased GFR. So this is known as tubuloglomerular feedback mechanism. Same thing is shown here. What is the role of macular densa cell? Let's say opposite, decreased arterial blood pressure. So decreased hydrostatic pressure in the glomerulus, leading to decreased GFR. This decreased GFR means decreased sodium chloride at the macular densa cell. Once the macular densa cells see that there is decreased NaCl or sodium chloride, it will cause increased release of renin. Two things it will cause: increased renin secretion, as well as decreases the afferent arteriolar resistance. That means previously it was like this, now it will become slightly bigger. So resistance will decrease. Dilatation, afferent arteriolar dilatation. So blood pressure or hydrostatic pressure will come back to the normal. Similarly, release of renin will cause release of angiotensin. Renin will cause conversion of angiotensinogen to angiotensin 1, and angiotensin 1 will be converted into angiotensin 2 by the angiotensin converting enzyme. Ultimately, renin release will lead to increased angiotensin 2 formation. This will cause afferent arteriolar constriction. It will cause afferent arteriolar constriction, and that's why it will inhibit the decrease hydrostatic pressure, and the regulation and the GFR will come back to the normal. Okay. This is how it functions. Second mechanism, which we say coming from outside. The one which is coming from outside is in the form of sympathetic nervous control, and this is for long-term control of the blood pressure. So if you remember from in CVS block, we said blood pressure is controlled by two ways: short-term control and long-term control. In long-term control, we say renal mechanism of control of blood pressure. So here it is the same. Renal mechanism for control of blood pressure is nothing but the extrinsic sympathetic control. It is mediated through the sympathetic nerve supplying to the afferent arteriole, and they are responsible for detecting the pressure in the afferent arteriole. If the pressure is increased, they will decrease the baroreceptor reflex mechanism, the baroreceptor reflex mechanism will increase, and this will cause the relaxation of the smooth muscle. So blood pressure will come back to the normal. This diagram is again coming from the CVS block. Increased arterial pressure will lead to stimulation of sympathetic nervous response. This sympathetic nervous response will be having everywhere, every part of the body, including the renal mechanism, renal arterioles. So renal arterioles will cause vasoconstriction. GFR will decrease, the pressure will decrease, leading to decrease in the GFR, and there will be decrease urine volume. When blood pressure increases, this is compensated by decrease urine volume and keeping conservation of the fluid and electrolytes, and the arterial pressure will come back to the normal. This is known as the long-term mechanism occurring through the kidney. Told you GFR depends upon two factors, basically two factors. One is net filtration pressure. Second one is KF, that is constant filtration of coefficient. This filtration of coefficient is although said constant, but it may change in diseases. Some of the diseases which we will see that in what conditions will lead to increase or decrease in the filtration coefficient. So filtration coefficient is not constant, but it is subject to physiological control, and it depends upon the surface area and permeability. Filtration coefficient depends upon surface area and permeability. Kidneys are receiving 20 to 25% of the cardiac output. We have seen in the previous lecture that they are receiving a huge amount of blood flow because they are cleaning the blood, that's or filtering the blood. That's why they receive excessive amount. Around 1,140 ml per minute, which is around 22% of the cardiac output, and they will be monitoring the ECF volume. They are monitoring the ECF volume. If the extracellular fluid volume is decreased, they will hold the water in and not allowing the water to go out. That's why they are controlling the osmolarity also. Now filtration coefficient, how it affects the GFR. Filtration coefficient depends upon surface area and permeability. Now it can be changed, the surface area can be changed due to contractility of that membrane. Glomerular filtrating membrane can get contracted and it will become slightly a little bit less, and that's why it will lead to decrease in GFR. or it may be relaxed so that the surface area will increase, even the slits or pores will increase. So it is indirectly changing the filtration coefficient. Filtration coefficient can be reduced in pathological conditions like this is physiological. They may contract and relax, but in pathology like in diabetes mellitus or hypertension or glomerulonephritis, inflammation of the glomerular membrane. Glomerulonephritis means inflammation of the glomerular membrane. In all these conditions, GFR will decrease. So long-standing hypertension or many years of diabetes mellitus or glomerulonephritis will lead to loss or decrease in the filtration coefficient, which will lead to decrease in the GFR. GFR will decrease or increase in the thickness of the membrane. This is normal at normal time, or maybe ordinarily. This is the size of the slit. Okay. When it get contracted, when the mesangial cells contract or the podocyte contract, they will touch each other and the filtration slits will be reduced. So GFR will be reduced. And this is ultimately the filtration coefficient, which is increased or decreased due to podocyte contraction. The podocytes are contracting or relaxing. The slit size will be increasing or decreasing. And that's why the GFR may be increasing or decreasing. Remember the conditions in which GFR is affected. So one is diabetes mellitus for long time. Yani. It's not today diabetes is detected and you will have change in the GFR. No, it is long term, maybe for years. If diabetes is not treated, then it may lead to the change in the GFR. Hypertension, increased blood pressure for long standing, maybe not 1, 2, 3 years, but many years. If many years, if the blood pressure is not controlled, then it will lead to change in the GFR. Prostate enlargement. In males, the enlargement of the prostate will create a negative pressure or a back pressure will lead to decrease in the GFR. All these conditions, diabetes mellitus, increase blood pressure or increase the size of the prostate will lead to decrease in GFR. Similarly, release of a hormone known as ANP. ANP stands for atrial natriuretic peptide. ANP. Coming from where? Where it will be released?
Atria.
Atrium, or it is coming from the heart. Right or left atrium, or it may be just simply remember that ANP is coming from or released from heart. There is one syndrome called as SIADH. ADH is what?
Antidiuretic
Hormone. SI means this is syndrome. Full form is syndrome of I for inappropriate release of antidiuretic hormone. Syndrome of inappropriate release of ADH is known as SIADH. This is excessive GFR. Increase in the GFR. GFR will be increased. So three chronic conditions will lead to decrease in GFR. One is diabetes mellitus, long-standing. Second one is long-standing hypertension, uncontrolled or not controlled blood pressure for long time, and also volume of the blood. If the person is lost blood, then there will be decrease in the GFR because decrease amount will come to filtration and decrease amount will be filtered. And also increased in the size of the prostate, which will create a back pressure on the filtration. this will lead to decrease in the GFR. The conditions which increases the GFR are ANP release of ANP excessive release, atrial natriuretic peptide. What it causes? It causes loss of sodium. Natriuresis means
Yes.
yeah. Natriuresis means natriuresis is equal to sodium in the urine. Sodium in excessive loss of sodium in urine. This is called as natriuresis. So this is causing loss of sodium in the urine. If sodium is lost, the blood pressure will decrease and the GFR will, the what sodium is anti-natriuresis. This is causing holding of sodium. It is sorry. Anti means opposite of natriuresis, loss of sodium in the urine. So sodium will be more into the body. This will lead to more water absorption. This will lead to more blood pressure or slightly more increase in the blood pressure, and that's why it will lead to increase in the GFR. Okay, how will you calculate the GFR? GFR, if suppose I want to know my GFR, how I will calculate? If you remember the diagram.
By maybe by the creatinine.
Yes, if you remember this diagram, if you remember the
By
diagram,
the clearance.
filtration means here, from here to here. So this is nothing but clearance of any substance which is filtered but not absorbed and not secreted. If it is a substance is like that, only filtered but not absorbed and also not secreted. So same amount will come out into the urine. Okay. So if you know how much it is coming into the urine, we can and you know how much is there in the blood, then you can say the same amount is coming. That means it is equal to the one which is filtered. This is called as uh, this is called as a clearance method. This much amount is cleared into the urine. So by knowing the plasma clearance of any particular substance, we can know the GFR. So two parameters are there. One is known as inulin clearance, which is a polymer of fructose, which is filtered, not reabsorbed, and not secreted. If you know the clearance of inulin, you can know the GFR. Or inulin, it is not a good thing to keep, or it's not possible for keeping the same concentration by infusing the inulin. That's why the doctors or scientists has decided to use a substance which is produced in the body, which is known as creatinine. If you know the creatinine clearance, you will ultimately say the GFR. So if the creatinine level becomes normal creatinine level is 1 milligram per 100 ml of blood. If creatinine becomes increased, let's say 5 milligram per 100 ml. That means the substance which was or 8 milligram per 100 ml. That means the substance which has supposed to be cleared is not cleared. That's why it will increase in the blood, and it is indirectly show you the GFR or filtration. So if filtration is more, the value should go down. If filtration is less, the value will go up. So creatinine level increases when there is decrease in the GFR. So plasma creatinine level is opposite to the GFR. 1 by GFR. So if level increases, that means GFR decreases. If creatinine decreases, that means GFR is coming back to the normal. Okay, this is the explanation of one lecture, that is glomerular filtration rate. We took a long time for this lecture. Okay. Any difficulty in this?
No. Doctor, can we take like a break for prayer?
Yes, I think so. This is good idea. But the next lecture will be little bit more lengthy. Little bit lengthy, yeah.
Okay. How much time? Maybe 10 minutes?
No, let us discuss this first, because now it is almost 1.5 hours. I took a long time for this one lecture. So is it okay to continue, or we will have another lecture tomorrow? This is my suggestion, my idea.
Actually, I'm okay with both.
What about others?